We will now begin today's webinar. This webinar is being recorded so those not able to join us today can listen to the program at a time that is convenient for them. A link to the audio recording will be included in an email to all members to be sent next week. My name is Katie Ramos, and I am the Program Associate for Goodwin House at Home. It is my pleasure to introduce our program moderator, Lindsay Hutter, the Chief Strategy and Marketing Officer for Goodwin House Incorporated.
Thank you so much, Katie, and welcome everyone. Thank you for joining us today to gain insights into how you can stay safe, healthy, and engaged during the upcoming fall and winter seasons amidst the coronavirus pandemic. For all of us in the Goodwin House staff family, the pandemic is certainly very professional. It is also very personal. The photograph that you're seeing on the slide is my first and primary role in life, and that's a daughter. I'm the Chief Strategy and Marketing Officer second. I'm a daughter first. And that's a photograph of my brother and my mother at the time, almost 95, when she relocated from Illinois to Virginia to live in Goodwin House, Alexandria. My father passed away at the end of October, and Mom, after spending almost 95 years of her life living in the state of Illinois, moved to be closer to me. And just as she got settled in her new apartment, about 3 weeks later, we began to implement very stringent protocols for the safety of our residents, our members, and our staff. I share this with you so you can see just how personal it is for all of us on the Goodwin House staff, whether we have parents, aunts, uncles, grandparents who are in a vulnerable population. We are laser focused on their health and their safety. The Goodwin House staff family is honored to support, honor, and uplift nearly 2,000 older adults across Northern Virginia. America is now in month 5 of the pandemic. We are grateful for the progress that has been achieved in understanding the virus, in new treatments, and in keeping people safe. At the same time, we are sober about the reality that while we may be done with COVID-19, it is not done with us. Progress on vaccines indicates one or several could be in mass production starting in January. That means we need to prepare to be safe and engaged until then, and possibly longer. And it's that fact that brought us to today's program, staying safe through the summer reopening and in the fall and the winter. And now for a few housekeeping slides and notes. You will see on the screen before you that you're going to see our presenter and her slides. You will be asked 2 polls, one fairly early, one near the end of the webinar. And then we're going to have about 15 to 20 minutes of Q&A at the end of our presenter's presentation. We've already received questions from some of you, and throughout the webinar, you can go ahead and through the chat function and the questions that you see should be on the right of your screen, you will be able to type in your questions. You can do that at any point throughout the webinar. So let's get just a little bit deeper on the poll. This next slide is going to show you the polling format. This isn't the actual poll yet, but it shows you what the format looks like. And so when it's displayed on your screen, after you've read the questions and the possible responses, we just ask that you choose one response. And then we'll report out to the audience the sentiment of the group. And just as we want to learn your views on the poll questions, as I mentioned, we're very eager to hear your questions for our expert speaker. So this slide shows you how you can pose questions at any point during the webinar using the chat function. I'm going to give you a minute just to take a look at this so you get familiar with it. So let's now review how we're going to cover this topic of staying safe, healthy, and engaged through the summer reopening and into the fall and winter. So here's our agenda. You see that I'm up speaking. I'm going to have a few more remarks for you. And then I am going to transition to our featured speaker, Dr. Margaret Gloria, Medical Director for Goodwin House Hospice. and then we'll field questions from you. So now, a little bit about who's bringing this presentation to you. Goodwin House believes that older adults should be able to age well and vitally wherever they choose. That may be in your home, it may be in a life plan community, it actually could be a combination of both. So for older adults, and there are many out there who say, I like my home, I think that's where I want to age. We developed something called Goodwin House at Home in 2014. Goodwin House at Home makes it possible for older adults to safely live in their home, have care coordinated for themselves as well as their home, and inoculate themselves from the future costs of unseen care needs or unanticipated care needs. And that's through a variety of contract and financial options. For older adults that say, gosh, I think I'd like to live in a senior living community, we have two, Goodwin House Alexandria and Goodwin House Bailey's Crossroads. Now, there are some older adults who said, I want to stay at home, but if at some point I want to move into a community, I'd like to do that too. And that's where portability comes into play. If you start by joining Goodwin House at Home and you decide, I think I'm going to move into a life plan community, you can do that. And we will recognize and credit the investment that you've made in Goodwin House at Home if you choose one of the Goodwin House life plan communities. Now, just as important as it is to make a choice and live safely where you want to live, it's important to have a variety of healthcare services available to you. So Goodwin House has several healthcare options to help you live safely wherever you choose to live. You'll see working left to right, Goodwin House Home Care. And this is a home care service that currently we provide to our residents in Goodwin House Alexandria and Goodwin House Bailey's Crossroads. And at some point soon, we'd like to introduce that to older adults across Northern Virginia. We also have Goodwin House Rehabilitation Services and Home Health. These are therapies and rehab services should you have a condition such as Parkinson's, or maybe you've had surgery and need some therapy before you're really ready to be fully independent and back into your old life. And then we also have Goodwin House Palliative Care and Hospice. And so these are services that we bring to older adults in our communities and across Northern Virginia. Now, I want to take just a minute and comment on our approach to COVID-19. Since March 2nd, Goodwin House has implemented about 165 different protocols for the safety of our residents, our Goodwin House at Home members, and our staff. It would take me all day to talk about those protocols. So what I did in this slide was just focused on 4 themes for you. And the first is our leadership focus. In late February, we organized a core team of our clinical and senior management professionals. That team meets daily. We refer to it as the Infection Precaution and Planning team. There are 15 of us, and we're aided by Dr. Gloria, one of our 2 medical directors. And that team is laser focused every day on what do we need to do to keep our residents, our members, and our staff safe. The second point that I would make is that Goodwin House has had a very proactive approach to the pandemic. We implemented protocols early, and protocols meaning safety protocols, moving away from communal dining. On March 13th, we made a decision that our campuses would close to guests and visitors, and only staff, residents, and essential personnel would be permitted. In addition, very early on, we adopted ongoing testing of our staff and residents, and that was in early May. We continue to test our care partner staff every other week. Non-care partner staff are tested every 4 weeks, and then we do baseline tests of our residents on a monthly basis. This is not because we're forced to. This is not because we've had big outbreaks. It's because we feel that's the right way to keep a handle on the virus and protect those that we serve. A third theme about our commitment to keeping our residents and our members healthy and safe is prioritizing engagement. What do I mean by that? Early on, the Goodwin House at Home team launched online events. By the end of May, they were online with virtual programming. They also set up a grocery delivery service for Goodwin House at Home members when, in the very early phases of the pandemic, Governor Northam said all older adults should stay home. In our life plan communities, we set up TV streaming internet programming, and socially distanced outdoor events and concerts for our residents. And finally, I want to point out our mission mindset. We're a very mission-based organization. And early on, when it became clear that PPE, personal protective equipment, was in short supply, we knew that as a single buyer, we could not obtain the PPE we needed. We gathered over 50 different organizations, some large hospital systems, and said, let's do this together. Instead of buying in the thousands, let's buy in the hundreds of thousands. And we can get attention from the global suppliers. And so we did that. Goodwin House became the procurer for over 50 different organizations to obtain PPE. In addition, we've widely shared what we've learned. And we will continue to do that because we feel that we are all in this together to support, honor, and uplift older adults. So what I'd like to do now is focus on insights that we can share with you to help you stay safe and engaged in the coming months and in the coming next fall and winter season. It's my pleasure to serve as a member of the Goodwin House Infection Precaution and Planning team that I mentioned earlier with Dr. Margaret Gloria. You will find her to be a calm, thoughtful voice on the coronavirus, and we are very grateful for her daily wisdom to inform our safety protocols. Dr. Gloria completed her fellowship training in hospice and palliative medicine, as well as internal medicine at George Washington University Hospital. She is board certified in internal medicine and hospice and palliative medicine by the American Board of Internal Medicine. Dr. Gloria proceeded a step beyond the American Board of Internal Medicine certification in order to become a hospice medical director. Prior to joining Goodwin House Incorporated, Dr. Gloria served on the inpatient palliative care team at George Washington University Hospital. Welcome, Dr. Gloria.
Thank you so much, Lindsay, and welcome everyone joining us today for this webinar. I'm so happy that you can be here with us. Just to start us off, I'm going to give us a quick update of the state of the pandemic in the Northern Virginia area, the state, the country as a whole, and globally. So just a quick recap. Here in Virginia, we entered phase 1 of our reopening plan. The state as a whole entered that phase on May 15th. In this area, Northern Virginia specifically, we were a little late to the party, and we entered phase 1 on May 28th. We all entered phase 2 on June 12th, and we all entered phase 3 on July 7th. So even though we're in phase 3 of our reopening plan, there are still some restrictions on most businesses. Most businesses, depending on the type, are still limited to 50 to 75% of capacity. Social gatherings are still limited to 250 people, et cetera, et cetera. So there still are some limitations. In the state of Virginia, we have to date, as of this morning, in fact, the Virginia Department of Health is reporting 74,431 confirmed cases of COVID-19. About 20,000 of those cases are here in the Northern Virginia area, so between Fairfax, Arlington, and Alexandria County. At the peak of, I'll call it the first wave, although I know that there's been some debate as to whether or not we can call these discrete waves. We'll go with wave for simplicity's sake right now. At the peak of the first wave, we were recording about 1,000 new cases every day in Virginia. We got that number down to about 500 cases a day at the lowest point. That was actually about mid-June. At this point, we're having a bit of an uptick. We're seeing on average about 620 new cases a day, and that seems to really have been going up since about the 4th of July. So on the slide in front of you, this is actually a post by Governor Northam. He posted this to his social media account on Friday, and he's basically kind of highlighting the fact that we here in Virginia are actually doing relatively quite well compared to, unfortunately, some of the other areas in the country. We are seeing quite an uptick in cases in the Hampton Roads area, so that's Newport News and Virginia Beach. I would guess, again, maybe associated with the 4th of July weekend and people wanting to get out to the beach. You know, Governor Northam wanted to kind of remind us all to stick with the basics because they work. So he says avoid large crowds, keep washing your hands, cover your face. And if you do see businesses that you think are flouting the rules, feel free to share that with your local health department so that we can all be in this together. one thing I wanted to point out, and it's actually in quotes, just so that it is clear that these are his direct words, not mine. He has said, "I won't hesitate to impose restrictions if needed." So if cases continue to rise in our state, and if we start to see anything similar to what's going on in other areas of the country, he has made pretty clear that he will step back some of those restrictions that we were under previously. So I know none of us want to go backwards, so let's in fact go forward to the next slide. And I'm going to talk a little bit about the state of the pandemic as, in the country as a whole. So I know you've all seen the news, and again, I've mentioned it in some areas, particularly in the South and the West, they're seeing huge increases in cases right now. They're running into situations where ICU beds are scarce, supplies are scarce, so definitely a place we don't want to be. Leaders in some of the hardest hit areas, including states like California, Florida, and Texas, have started to talk about going back to stricter restrictions. And in fact, since I've made this slide, they've already started in some cases to impose more restrictions to try and just get this new uptick under control. So unfortunately, because of the surge in cases that we're seeing around the country, we're also starting to see that the labs are taking longer to run the tests for COVID-19. At the best point, we were expecting results back within about 24 to 72 hours. At this point, it's taking more like 4 to 70, even sometimes 10 days to get the results back for COVID-19 testing. And again, that's just because the labs work nationwide, those supplies get distributed nationwide, and so the uptick that we're seeing in other parts of the country are affecting us even here. Our numbers as a country as a whole, we have just over 3.4 million cases of COVID-19 that have been confirmed, and we've had just over 137,000 deaths so far. So let's look at the pandemic globally. On this slide, you'll see these are two graphics from the New York Times. I wanted to just mention that the New York Times right now is providing free access to any article related to COVID-19. So if you don't have a subscription, you still have free access. If you wanted to go online, they have a lot of graphics just like this one that are very neat. So worldwide, we have over 13.3 million cases of COVID-19. There have been over 580,000 deaths. If you look at the slide here, that bar graph on the left-hand side represents, again, a 7-day average of the new number of cases reported every day. You can see that there was an uptick at the end of March, and then in April and May, there was actually a plateau, whereas globally, we did a pretty good job of keeping the number of new cases at least steady. And then since then, in about June and July, it looks like it's been upticking, and we have about 200,000 new cases reported globally every single day now. If you look at the map on the right-hand side, it's color-coded to represent areas of the world where the cases are going down. So those would be the countries in light blue. Areas in the world where countries or where cases are staying about the same. So that would be the area that's in yellow. And then areas of the world where the number of cases is rising are represented in different shades of orange and red, red being with the most number of new cases. So you can see Australia is in that dark red, the United States and Mexico and a few others are in that orange color. So definitely seeing an uptick, excuse me. So that's the state of affairs locally, statewide, nationwide, and globally. So I wanted to talk a little bit about how much I recognize that sometimes it can be overwhelming to hear these updates and to read the news. And for myself personally, sometimes I feel like, is there even an end in sight? So I wanted to focus the next few slides on the silver lining in all of this. One of those being what we've learned so far. So when SARS-CoV-2, which is the virus that causes COVID-19, was first discovered in the end of December of 2019, we didn't know that much about it. And in just a few short months, we've learned a lot. So some of the things we've learned have been about how it's transmitted. Initially, we were thinking that transmission by contaminated surfaces was a big concern. Now we're realizing that it's more transmission through the air. And I'm sure you've heard there's been a lot of talk in the media lately about airborne versus droplet spread. I think the reason for the confusion is there's not really a definitive scientific definition of what makes airborne versus droplet. Basically, what we've always said is droplets are rather large, respiratory droplets. You could almost see them even, they're so large. And that's, the things that get shot into the air when people cough or sneeze. Airborne means that the viral particles can actually suspend themselves in tiny little droplets that are more microscopic, that you can't see with the naked eye. The difference being that those larger, heavier droplets fall out of the air quicker than the airborne particles that are smaller and tend to stay and float longer. The important thing is recognizing that if it can float around in the air for some period of time, maybe even an hour or more, that means that we need to take special precautions, being indoors and being in areas where there's not a lot of circulation, even if you're not right in that general vicinity with somebody. Somebody could be, say, in the grocery store and have left already, and there could still be viral particles in the air. So each and every one of these little things that we learn is another weapon to add to our arsenal to try and battle COVID-19. So that's one that's huge. That's going to help us a lot as far as limiting the spread. The mortality rate, I wanted to mention, we've improved here in the United States. At the peak, we were seeing a mortality rate of close to 7%. And now it's closer to 2%. So that's a huge improvement, and that's really great. And that all has to do with all the things that we've learned and the way that we've learned to manage resources and such so that we don't run into scarcities. We've learned that proning patients works. I don't know if you've heard about this, but it's not a new concept. Patients that are intubated in the ICU typically lie on their back because of the way that all the machinery and the tubing needs to come in. It's just safest and easiest to have that person lying on their back. But people that have serious lung problems actually benefit from being flipped over onto their stomachs. So there are special beds that they make for the ICU that can actually rotate a patient onto their stomach. So they're doing that in most major ICUs where they have those beds available to them, and they're finding that that's improving mortality rates in patients. Identifying high-risk patients, there's more and more mounting evidence. That hasn't changed. That's been the same as what we've always, seen, that people that are elderly, that people that have a lot of health problems, lung problems, heart problems are at higher risk of not doing well with COVID-19 infection, but we're finding more and more and more evidence to support that theory. We found that remdesivir works. So remdesivir was approved. It was given emergency use approval by the FDA for the treatment of COVID-19. And in the first preliminary studies that have been done, it's actually been shown to improve mortality in patients that are critically ill with COVID-19, so that's great too. There's going to be more drugs just like it. That's an antiviral drug coming through the pipeline now that we know that remdesivir works. We know that social distancing works. We saw that when we flattened the curves, both globally and in the state here and locally here in Northern Virginia. On the right-hand side of the slide, I just wanted to share with you all, in the vein of what we've learned, there is a site, it's called Lit COVID, and it is a compilation of articles, journal articles, medical literature that have been compiled all together in one place. There's more than 30,000 entries on that website, freely accessible to the public, to any doctor, to any scientist that wants to log on and see. They're organized by category, so you can search under categories like treatment, diagnosis, management of COVID-19. They're organized by which journal they've been published in, so major journals like the Lancet and the British Medical Journal are included there. And then they're organized by geographically where the research has come from, because that's important too. Because of genetic and environmental factors, what may be true in China may not necessarily be true here in the US. So if you're a doctor and you wanted to look at a treatment that's helpful for your patient demographic here in the US, you could log on. That map that you see represents the countries that have contributed the most data. The darker blues, are the countries that have given most, and then the lighter blue shades still have given, a fair amount of information. So it's things like that that really make me hopeful that we're learning more and more every day. As Lindsay mentioned, Goodwin House is sharing everything that we learn. It seems like everybody's really coming together to do that in the scientific community so that we're all in this together and on the same page. I wanted, while we're on the subject of what we learned, to also talk about an article that I found in the Wall Street Journal that I found to be very interesting. Early on, we had talked about how we had projected and certainly hoped that over the summer, the number of cases that we saw of COVID-19 would drop as the weather, got warmer and more humid, and therefore not as hospitable to the virus. Katie, if you could go one slide forward. We're finding, though, it seems as though that's not happening, because we're seeing an uptick in cases, even if it's a small uptick, in various places, and in some places, like I said, very large upticks. So what happened there? I was wondering myself. I saw this article, and so like I said, I thought I'd share it with you all. So it turns out that sunlight does kill COVID-19. We have research that supports that. It turns out that COVID-19 does deteriorate more rapidly out in warm, humid weather. So that's great. We thought that both those things would be true. But the catch is that herd immunity turns out to be a bigger factor in all of this than the climate changes, that we had hoped lead to less spread of the virus. So it seems that even though outdoors at the beach and by the pool, the transmission is less, we're still seeing a fair amount of transmission indoors in areas where there's not a lot of sunlight and not a lot of circulation necessarily. The article also went on to point out that testing and contact tracing are critical, in being able to limit the spread of the virus. And I think that's one of the issues that we're running into now. I mentioned earlier that labs now are taking between 4 and 7 and even 10 days to get results back of COVID-19 tests for us. What that means is that if you get exposed, let's just say at the 4th of July, you're at a party, you don't typically develop symptoms until about 5 days after that. So that's about July 9th. Say you go get a test. It takes a week, that's July 16th. You've probably been contagious since about July 8th, so you have a solid week where you've been contagious and you've possibly been spreading the virus around, even if you're not symptomatic. And so that's a lot of time that we lost where we could have quarantined you sooner and traced your contacts and what have you. So I think that's all contributing to why we're seeing the uptick right now in cases, and that's why making sure that we have access to ready tests and rapid tests is so important. The other thing, going back to herd immunity, is, we've talked about herd immunity. It's what we're hoping for if and when we finally have a vaccine. But keep in mind that experts recommend that people, the population, be about 60 to 70% of them be immune to that certain disease before you actually have herd immunity. So there are 325 million people in the US, approximately. That would mean we would need roughly 200 million people to be immune to COVID-19. And if you put that in the context of we have 3.4 million people that have had it already, we still have quite a long way to go. Quite a number of people that we need to vaccinate before we get to that point. So obviously we're still learning. This is yet another thing that we learned. We're going to keep learning as we go, which brings us to updates on treatments and diagnostics. I have some really good news about the vaccine development. So there are several pharmaceutical companies that are working on this right now. AstraZeneca is a large pharmaceutical company, and they've partnered with Oxford University. They're currently in England in their phase 3 trial of their vaccine development, and they're planning on moving to the phase 3 portion of their trial here in the US in August. So that's great news. Sinopharm is a large pharmaceutical company based in Wuhan, China. They're also in phase 3 of their trial. They entered phase 3 in June. Moderna has partnered with the NIH, and they are in phase 2 of their clinical trial. They were scheduled to enter phase 3 this month, but they have not released the data from phase 2 yet, so it's unclear as to whether or not they're going to be able to keep up with that schedule, but they're almost there. And then there's a handful of other large pharmaceutical companies that you've probably heard of, Novavax, Pfizer, Inovio, on, that are all in various stages of phase 1 and phase 2 clinical trials. I wanted to real quick recap. So phase 1 clinical trials are when basically they're making sure that whatever it is, the vaccine or the medicine is safe, and they're deciding upon what dose factor, or what dosage they should give a patient. That usually takes several months. And then about 70% of drugs and vaccines that are entered into phase 1 trials move forward to phase 2. Phase 2 is really where they really try and sort out side effects that may be caused. It can take a couple of years, and I want to say 30% or so of all of the drugs that enter phase 2 move on to phase 3. Phase 3 can take also between 1 and 4 years, and that's basically where they can compare the drug to an already existing drug or to a placebo, and that's where they're really proving that this medicine or this vaccine has a positive effect in a given population, so it actually works. After phase 3 trials, that's generally when the FDA approves drugs and vaccines. And then phase 4 trials are much longer term. They go on for years and years, and they continue to collect data from thousands and thousands of patients about safety and side effects and all that other stuff. So the fact that we have vaccines that are already in phase 3 in such a short period of time is truly amazing. Some of these drug companies even think that they might have prototype vaccines available to at least a limited number of the general public in October. So that would really, really be neat if we could do that. The other thing I wanted to talk about as far as treatments go is dexamethasone. So early on in the pandemic, there was a study done in China that included about 40,000 people that showed that steroids can actually be harmful for people with COVID-19. There was another very large study done in England that showed that dexamethasone, which is a very inexpensive, popular steroid that we use often, can actually improve mortality in patients that are critically ill with COVID-19. So if that were true, that would be also really amazing. The catch to that is that they have not released their data yet, and it hasn't been peer reviewed. So it's very early to be able to say for sure that dexamethasone helps, but we'll take any good news that we can get. We'll go from there. I hear a lot of questions about antibody testing. So antibodies have been really tricky. There is technically no firm data that we do actually develop protective antibodies to COVID-19. Based on what little we have on COVID-19 and also what we have on other coronaviruses, the medical community is pretty darn sure that we do develop protective antibodies. We just haven't proven that yet. Some more recent studies have shown that these antibodies specifically to SARS-CoV-2 only last about 2 to 3 months. So that would be less than I was hoping for, but we'll see. We're still learning. The antibody tests themselves, we're finding are unreliable in both ways, in the sense that we get false positives and we also get false negatives. So they're good when we're using them on a population health level. So for example, if we wanted to study a certain population and see what percentage of that entire population has antibodies to COVID-19, for example, if we were thinking about herd immunity and whether or not we had herd immunity in a certain area, that's when those antibody tests would be helpful. Currently, given the limitations of the test, in the current situation that we're in, we're finding that those antibody tests are not useful yet, but let's hold on to them because, again, in the future, they may actually prove to be very useful. In the meantime, other types of tests are being developed, including saliva tests, which can be done at home. They're designed, for people to be able to take them at home. And so those are doing fairly well in development so far. And if they continue to do well, they would be a game changer for sure as far as testing for COVID-19. Imagine if you could do that at home and send it in and get a result back. That would be great. All right, so my last slide, I wanted to just kind of wrap up tips and guidelines as things open up. I know you're tired of hearing it, but keep washing your hands, keep social distancing, keep covering your face, stop touching your face. These things work. We know they work. We've shown that they work, in the past. We just have to keep with it. Remember, as things are opening up, as you're making decisions to go out into the community and see your families or what have you, any environment that's enclosed with poor air circulation and a high density of people is going to be high risk. So any area where you're in an enclosed space where people are talking loudly or yelling or singing or what have you, that is going to increase your risk of catching the virus because it increases the amount of viral particles that get put into the air as people are talking. We've had a couple of cases of, they call them super spreader events. One you might have heard, it was in the media. It was a choir practice where they practiced together in an enclosed space for about an hour, and because they were singing, raising their voice and exhaling forcefully for an hour, a large percentage of the people that were there for choir practice actually got sick with COVID-19. And then additionally, another example of that would be the meatpacking plants, where they're finding that a lot of people are getting sick. A big part of that is probably that when you're in one of those plants and the machines are working, it's quite loud. So when you're trying to talk to your colleague and your coworker, you're raising your voice, you're shouting, and therefore you're aerosolizing more viral particles. So keep those things in mind as you're making decisions over the summer about where you are and are not going to venture out to. And then I just wanted to mention there's mounting evidence that wearing even a cloth mask does absolutely, yes, help you from spreading the virus, but it also helps you from catching the virus. There was a study, I don't know that it's reliable, but there was a study that came out recently that said it could reduce your risk of catching the virus by up to 65%. So that would be huge. So that's very important. All right, and that's all I have for today, Lindsay.
Well, the truth is that's quite a bit, Dr. Gloria, in terms of recognizing how much we've learned, not only from a scientific and research perspective, but our healthcare professionals in the treatment in hospitals, and certainly how much we've learned as a senior living and healthcare services provider. So thank you for distilling it in a manner in which even if we're someone that doesn't have MD behind our name, we can understand. So we've had a lot of questions come in. I'm going to field the first one, and then I think the majority are going to go to you, Dr. Gloria. The first question was, how many COVID cases has Goodwin House had? And what I'm going to do is report on Goodwin House Alexandria and Goodwin House Bailey's Crossroads. I'm not going to report on anyone that we might be treating in hospice or home health. So with respect to COVID cases, Goodwin House Alexandria has had one resident. It was a resident in independent living, and that resident was completely asymptomatic. And it was caught as part of our ongoing and routine testing. And that resident is perfectly fine and out of isolation right now and is tested negative. Goodwin House Alexandria has had 15 staff cases. I think all but two were asymptomatic. And we have 3 current cases, and we have 1 staff member who is pending test results to return back to work. So what that tells you is if we've had 15, 3 are current, that's 12, 1 pending return to work based on our return to work protocol. That means that the other 11 have all returned back to work and tested negative. So there's a very, very high recovery rate there. At Goodwin House Bailey's Crossroads, we have had 7 residents that have tested positive for COVID. And very sadly, heavy on our heart, 2 of them, older and with underlying conditions, passed away early in the pandemic. And I think that goes to show how much the hospitals have learned since then, that the mortality rate has declined. We've had approximately 3 dozen staff members at Bailey's Crossroads test positive. That is a slightly larger campus, so population percentage-wise, you would expect that. Currently at Bailey's Crossroads, there is 1 staff member that is positive, 3 that are in the return to work testing phase. All others have recovered. So that is the situation with respect to our 2 life plan communities. And very, very, very thankful to report no residents are COVID positive at either Goodwin House Bailey's Crossroads or Goodwin House Alexandria right now. So let me jump to the questions. This comes from Michael, and he said, what are your hopes for improving the turnaround times for test results?
Oh, that's an excellent question. And you highlighted that I forgot to tell you all something very important and very exciting. So a lot of the labs are moving to a new technique of testing, which they call pooled testing. And so basically what they do is they take 20 samples and they take a little bit of each of those 20 samples and put it into one test tube, put that in the machine and run it. If that's negative, all 20 of those samples are negative and they can move on at lightning speed. If it's positive, they have to go back and individually run all 20 of those samples to figure out which of the 20 made that batch positive. But still, they're saving a lot of time. So that's one thing that the labs are all transitioning toward currently if they haven't gotten there already. And that's really going to help as far as processing things quickly. The other thing kind of goes back to using the saliva tests and the other methods of testing. We actually at the hospice are already using saliva testing to screen our staff. And so that doesn't actually require the swab that it usually takes to go up the nose, which is one of the things that is in such short supply right now. So by using those other methods of testing and limiting the number of swabs that we're using, that's also going to help too. So as these other tests get developed and our more widely accepted and more validated, I think testing is just going to get better and better.
When I hear about the innovation of pooling in the test results, I just want to go hug the test people who came up with that. It's very encouraging. So we've got a couple of questions on masks, Dr. Gloria. One is, and this comes from Daniel, what is the best mask material that's commonly available?
So I think the best mask material remains a cotton type material, and I do think that layering a mask so that there's more than one layer, remains the best. I've certainly seen a lot of the cloth masks that are just one layer, they're quite thin. That makes it certainly very easy to breathe through, but it is probably not as effective at reducing the amount of viral particles and little droplets that you're exhaling out into the environment. So probably a cloth mask that's made of some kind of cotton material that has double layers, I would say. To answer that, to move up, the surgical masks are even better than the cloth masks, generally speaking. And then the respirators that we wear, of course, the standard, the gold standard as far as protection.
Okay, and so we've got one that's come in, which is if I am outdoors and I walk at a socially distanced pace with a friend, do we both still need to wear masks?
Well, that's a good question. For me personally, when I leave the house, even when I know that I am not necessarily going to be closer than 6 feet to anybody, I have a habit of I put my mask on when I walk out the front door. I don't touch my mask the whole time that I'm in public, and then when I come home, I remove my mask. That's more for me so that I remember to not touch it, to not contaminate it. If otherwise I'm taking it off and putting it on, I've lost it, what have you. I think if you're truly going to be at least 6 feet away from somebody outdoors where there's plenty of circulation, your risk is minimal. It's never no risk, right? But it's probably pretty low. I would err on the side of safety, and I would probably wear my mask if at all possible, just to be safe.
Okay, and I want to apologize. It was Shep that asked the question about the best mask material. It's Daniela that says, how many times can you use a surgical mask?
Oh, okay. So great question. Right now, from the CDC and the WHO, the best guidance that we have is that you can continue to use a surgical mask until it's visibly soiled. So it depends, kind of.
I'm gonna jump from mask and move into some other topics. So this individual wrote in advance and said, is Goodwin House advising residents or Goodwin House at Home members to consider a COVID-19 addendum to their living will or an advanced medical directive, given the pandemic?
Yeah. Early in the stage of the first wave, again, I'll call it, I felt really strongly that people should not necessarily addend their advanced directive, but at least go back and review it and make sure that it is still current and that's what you would actually want. Now things feel a little bit more relaxed, but I still think that it's always a good idea to go back and review your advanced directive and to talk specifically with your family about cases that are specific to COVID-19. So some people, for example, have voiced that if there were a situation where there was a scarcity of ventilators, they would not want a ventilator, for example. They would not want to know that they had taken a ventilator from, a young person or what have you. So if you have anything that may be specific to COVID-19, or again, if your advanced directive may not be necessarily up to date, I do definitely recommend you check it and update it if that's the case.
Okay, next question. When do I bring my housekeeper back? And when do I allow others into my home? Family, friends, in other words, non-essential people, although we know that family and friends are essential, but I think you understand the context of this question.
Right. And unfortunately, I don't have a definitive answer to give you. I think for the foreseeable future, if it's at all possible to meet with family and friends in an outdoor environment where you're not, inside, again, where you have more airflow, et cetera, that's better. Anytime you can social distance, that's better. But I think every case is going to have to be specific. So I think there's a lot to be said about your mental health and how much you miss your family and your loved ones and how much you want to see them. And so it has to be kind of a risk-benefit decision that you've personally considered yourself in your own circumstance. Just know, again, that anytime that you are interacting with other people, there is some risk. The risk just varies between minimal to, great risk. If you're, for example, in a crowded bar where there's a ton of people, I don't think that's going to be the case. But I think every person kind of has to weigh that personally and make a decision.
Okay, thank you. So this question comes from Kathy, and she wants to know, is meal carry out, pickup, delivery safe?
Yeah, so the general consensus is we are thinking that that is safer than we even thought at first, because now we're realizing that the transmission is so much more through the air and not through surfaces that are contaminated. So as long as you're washing your hands before you're eating, it should be safe to order food out. And I think most places are dropping off on the doorstep these days so that you're not even interacting, or if you go in to pick it up from a restaurant, let's just say you wear a mask when you go in and pick it up and then come right back out, so you're not in there for an extended period of time or what have you.
I'm going to add in something that the local health departments, Fairfax County and Alexandria, which are the two bodies that have jurisdiction over Goodwin House Alexandria and Goodwin House Bailey's Crossroads, shared with us early on, because residents had a concern about spending time in an elevator with other people. And what the health authorities indicated was, if it was 15 or more minutes of sustained exposure, you would have some risk. But riding up in an elevator would probably not give you risk, particularly if you were all wearing masks. Is that the case?
Yeah, generally about that 10 to 15 minute period of time is what is considered the breaking point between high and low risk. So if you're, again, walking into a restaurant just to pick up the food and walk back out, you're less than 10 or 15 minutes. You're in an elevator, you're less than 10 and 15 minutes. Your risk is still considered low.
So this next question is from Jenny. She says, taking temperatures of nursing home staff is used to identify if the staff member has a virus. Is that really a good indicator, since it is possible? And I'll acknowledge Lindsay shared so many staff have been asymptomatic that did test positive within the Goodwin House family. What options do nursing homes have? My mother lives in a nursing facility that takes the temperatures of staff.
So my answer to that would be, yes, I absolutely acknowledge that taking temperatures is not a foolproof way of catching, every case of COVID-19, because certainly there are people that are asymptomatic, but it does catch some. And in my opinion, every single case that you can catch in a staff member that's around residents of a nursing home or populations that are at risk is something. So taking a temperature is something that's non-invasive. I don't bat an eye at asking my staff to take a temperature every day. I think that's well worth. It's something.
I'm going to take this question, Maggie. It comes from, let's see here, Kim. And Kim wants to know, how is Goodwin House handling the reopening so residents, families, and friends can visit? And what I will share with you is that in June, about the second week of June, we allowed family and friends to come and visit residents that were in independent living, not assisted living, memory care, or health care, but in independent living. And the conditions were the following: that they needed to have a COVID test within 5 days of the visit, and it needed to be negative, that they would be screened when they arrived and go through our 6-question screening protocol, which is for all residents, all staff, and all essential personnel. Every time you come in the building, you're going to have those 6 questions and your temperature taken. So they would go through that screening process, and they actually would do that outside. They would never enter the building. And we had made arrangements for outdoor visitation areas, socially distanced, masks on at all times, and no eating or drinking. And we implemented that about the second week of June, and that continues. We're pleased that it's been able to continue. It would be rescinded if we had any significant outbreak of COVID cases. What's also very positive is that we were given permission by the local health authorities, and based on the Virginia Department of Health guidance, that our healthcare center residents and our assisted living center residents could have the same type of visitations outdoors with their family and friends. And the visits are for 45 minutes each. So that is what's in place at Goodwin House. And the healthcare and assisted living visitations just happened a week ago. So that is more recent. And those, of course, are our more vulnerable older adults in our communities. Another question for you, Dr. Gloria. Does the recent change with data now being collected by HHS and not by the Centers for Disease Control affect the Centers for Disease Control's ability to continue to provide guidelines related to the virus? From a medical perspective, what does this mean?
So, I would hope that the two agencies would continue to share data freely, not just with each other, but with the public at large. It might be actually advantageous to have that data reported more centrally, because the Department of Health and Human Services actually has a better ability to, for example, determine which resources need to be delivered to which area. So there could be shortages in some area and surpluses in others. And a more centrally located brain, if you will, is always going to be better than the CDC, for example, that has some limitations as far as that goes. But again, the hope would be that they continue to work collaboratively and share data between each other. But I do think that a more federal, if you will, centralized response in general would be helpful in this pandemic.
Yes. And you and I were talking about the ability of a centralized approach to deploy medicines, equipment, and PPE where it's most needed more quickly. And that's
right. And that is typically the way that we respond to any disaster, right? I mean, that's what FEMA is. That's typically how it goes.
Right. So we have another question, and it is related to mask again. And it says, given that older adults often have hearing conditions, would it be better to wear a face shield and not the mask when speaking with our friends or family who have hearing conditions? And is this safe?
I love that question. So the face shield specifically protects you from droplet sprays. So those are those larger droplets that people are going to cough or sneeze out. The face shield doesn't protect you from those aerosolized droplets, those very, very small microscopic particles that could float right under the face shield and into your mouth. So I don't think that the face shield is a good replacement for a face mask. I think both is excellent.
Very good question. This is from Shep. Can you give us insights on the mortality rate for older adults and how that has improved since the pandemic began?
Well, I think there's so many factors that go into that question. Part of it is just prevention, recognizing our populations that are at risk and taking the steps to protect them, which has been a really, as somebody who's played a major part in it, interesting, innovative, new experience, for all of us. I think part of it is also knowing what treatments work and what doesn't. I mentioned the proning already. I think very soon down the line, they'll be using dexamethasone more often and remdesivir, those kinds of things. And I think also as we continue to develop the testing and contact tracing, early identification of cases that are, I'm talking about even people that are sick, not necessarily people, in the sense of spreading it, but the person that's sick, knowing early on that person has COVID-19, even if they're fine at that moment, which oftentimes people are, just knowing that they're high risk and we've identified them and we know that we need to be keeping a very close eye on them. I think, there are so many things that are contributing to reducing the mortality overall, but particularly in our older, more vulnerable populations.
We have a question on the vaccines, and it relates to the compressed period for the trials and moving the vaccines into a production mode. And what are the risks, and should we feel comfortable with the vaccines that emerge?
One of the major risks that the medical community worries about is a vaccine is intended to cause an immune response. And so if that vaccine causes an abnormal immune response, that could potentially be a very bad situation. So I think for these very early trials, letting younger people that don't have more, medical comorbidities line up, and they are, so far people have been very generous about volunteering to participate in these studies. I think that's helpful. And I think as time goes on, we'll know which are safe and which aren't. Some are not going to be safe, and some are not going to make it all the way through these clinical trials. But I think as much as there's been a debate about rushing the development of these vaccines, I think, again, it's a risk-benefit type of situation. And so when you look at the benefit of having a vaccine to COVID-19 versus the risk of there being a side effect of that vaccine, which are rare to start with, side effects from vaccines, I think the benefit of the vaccine far outweighs any risk. So
I'm going to answer a question that has come in, and it is about Goodwin House and when we might allow priority club members or prospects who are interested in touring our communities to visit, and what is our timeline for that. So I'm going to take a step back and say that we're still in a mode that only staff, only residents, and only very essential personnel are permitted to come on our campuses. Family and friends visiting can come on the campus, but they have to stay outside. So it's only residents, staff, essential personnel that can actually enter the buildings. We do allow new reservists. These are individuals that have reserved an apartment to come in and directly go to that apartment that they've reserved and make their plans to move in. So we have developed protocols throughout the pandemic to allow older adults to move in to apartments safely. When they do, they are in a quarantine period, and that gives everyone confidence that they will be safe if someone might have the virus. We've not had anyone move in who has had the virus. So at this point, and you're seeing the poll up on the screen, so just bear with me 1 second and then we'll take the poll. At this point, we are not planning in the near term for any visitors to come and engage in social events in the building or any of the marketing events that we have historically held. Our sales team is undertaking virtual tours, and they do virtual video tours all the time, and we can do virtual tours of the community so those that are interested can see the community and can see a variety of the apartments. So right now, what we're going to do is ask to get your opinion, and you've got the benefit of Dr. Gloria's expertise. And so we'd ask you, will you take our poll for us? And here it is before you. As we move into fall and winter, what is your single biggest concern? And there are 5 answers, so we'll give you a minute to read and respond. Okay. Social isolation. 56% of you said social isolation and being confined inside is your #1 concern, and that's by a long shot. Second up, potential home repairs and maintenance at 26%. And then in single digits, the other 3. All right, very interesting, very interesting. There was a story that posted in, I believe it was USA Today yesterday, on activities for older adults to avoid social isolation. And I'm actually now going to ask Katie to advance the slide to resources from Goodwin House. And Dr. Gloria, if you'll stay with us here as we wrap this up. What you see before you now is the dedicated COVID-19 landing page at the Goodwin House website. And if you just go to goodwinhouse.org, you'll see that a yellow bar, it's called a hello bar, pops down at the top, and it says COVID page, read here. And it will take you to this page. And this is a compendium of all of our public statements, all of our updates to family and friends, all of the resources that we have developed and made available to our residents, our members, and the broader public. Now, if Maggie clicks the next slide, when you see it come up, across the top, it's a little hard to see, but there are 4 tabs right at the top. One is in teal blue, and the other 3 are in yellow. And when you get to that COVID landing page, those 4 tabs are full of resources that you can access at no charge. And they address topics such as those that Dr. Gloria has just reviewed: how to stay safe, how to stay healthy, what you can do to stay socially engaged, fitness activities that you can undertake in your home. These are programs that have been put together by our fitness directors. So I encourage you to go to our website, goodwinhouse.org, and click on that yellow Hello COVID bar, and you are welcome to access these resources. And if you have more questions about how Goodwin House is approaching the pandemic and keeping our residents, members, and staff safe, all of that information will be there. So as we flip to the next slide, I want to let you know there are some upcoming webinars that we have in queue. We have one next week, which will be staying at home with Goodwin House at Home. And this is about our Goodwin House at Home service, which helps older adults age in place safely. That's July 21st at 1 p.m. The following week, we have a webinar with 2 national experts on financial and long-term care considerations. That webinar is titled Study Up and Plan, the Pandemic's Impact on Long-Term Care Affordability and Access. It takes place July 28th at 11 a.m. Now, those 2 are in queue, but we'd like to know from you, what are topics that would be most helpful for us to present and make available to you? So Katie's put the next poll up, and you'll see that there are 5 different topics that you can select from. So we'll give you a minute to select the topic of most interest to you for future Goodwin House webinars. Okay, wow, we have another very, very strongly popular option here in terms of future topics. And Dr. Gloria, I think you should stay on retainer with us for these webinars. COVID-19 update, treatment, vaccine, and other updates. 42% of you said that would be your #1 topic. And tied for second, local real estate update, preparing your home for sale, and meet and greet with Goodwin House leaders. Well, thank you all. That is fantastic. You've given us really clear guidance on upcoming topics, and we will program accordingly. So one last thing before we conclude, and thank you for that second poll. I want to give you some contact information. If you have further questions, if you'd like to learn about Goodwin House at Home, you'd like to learn about Goodwin House's Life Plan communities, or you might want to learn about Goodwin House Home Health or our palliative care and hospice program, you can contact us at this phone number and this email. And I'm going to pause for about 20 seconds so you can write them down. All right. Well, with that, I want to thank Dr. Gloria, who I think is going to be brought back for what I believe will be your 4th webinar, brought back by popular demand. And we will get that scheduled, ladies and gentlemen, and we'll try to do it when there is sufficient new content that Dr. Gloria can share with you. And we've been featuring her about every 2 months, so that's likely the timeline that we would think about. I want to thank our viewing audience for giving us an hour of your time and allowing us to hear from you, your very thoughtful questions, your input and guidance to us on future webinar programming. And as previously noted at the beginning of this webinar, we will send the questions and answers in written format next week. I know that we were not able to get to all of the questions you sent in. My iPhone, which Katie was sending me all your questions, it was kind of exploding. So there's a lot of good curiosity you have about staying healthy and safe, and we want to help you with that. We'll also send along a link to today's recording. So if you want to play it back and listen again, or if you'd like to forward it and share it with family and friends, you're welcome to do so. From all of us in the Goodwin House family, please stay safe, stay engaged, and do feel welcome to reach out to anyone on the Goodwin House at Home team or the Life Plan community sales teams if we can be of support of you. Thank you, and this concludes today's webinar.